Time for lesson 3 of the workshop, Gender in Research. It is about gender-sensitive implementation. And Sabine Oertelt-Prigione will tell us about her implementation strategies.
Welcome to the third lecture, and this time about gender-sensitive implementation. What we will be talking about today is, well, first of all, what is implementation or knowledge translation really? What do we mean by it, and which different phases does it include? Then how is implementation research being done in the context of sex and gender-sensitive research or healthcare, or is it being done or not? Then I will walk you through kind of a practical example in trying to show several different layers that we need to take into consideration when we try to implement innovations in healthcare in the broadest sense. And then I have some general considerations that I would like to share with you. All right, so let's begin with what implementation is overall and where does it come from. So there's basically several phases in our process of coming up with a new idea or product or solution in healthcare, and finally this, let's say, product or innovation making it to the general process of healthcare. And all of these phases include different steps, different types of research, the groups of, for example, animals or people that are being included in the research are bigger or smaller or different, and the questions we're asking are different. And so as you can see here, there's two big divides in one way or another. So the first step is really from bench to bedside. So that's the translation from everything that we find in the lab by studying cells, by studying animals, and how do we translate that into something that actually gets to the patient or the person. And then how do we make sure that the product now that we have translated for use in humans or for application in humans, how do we make sure that that actually ends up in practice? And practice can be, on the one hand side, clinical practice in, for example, a hospital or a practice, or how does it end up in the broader world out there? So how does it become, for example, a public health intervention? And so the different phases we have here in terms of translation are T1, which move us from bench to bedside, T2, that moves us from bedside to practice. And this is now divided into a first T2 phase, which really makes it applicable to clinical practice, and then the T3 application to the population. And if you want, you can also take another step, which is T4, which is really how does it translate in the long run into application for population science. This is a summary, again, of these phases, and what I like to point out here is really the third column, where it is more clearly defined what we're trying to do. And as you see, the T0 and T1 are mostly focused on developing molecules or interventions and really coming out with either an understanding of a process or a product. Then we try in the T2 phase to translate that to the patient. So how can we make sure that a compound is safe, that it is effective, that it can be administered to human beings? And then in T3, we translate this information into a wider scale. So think about, for example, moving from the phase 2 trials to phase 3 trials, or doing population studies and trying to find out if something is really efficacious and how can we implement that into our practice. And the last one, the T4, as you can see here, is really the question is, what's the benefit to society, which is a nice way of phrasing it. But now that we have this product that works in a controlled clinical setting, what happens if we actually do it in our everyday care practices, in our everyday work, and how can we translate it to that? And you also see down there the valley of death, which is oftentimes used slogan because things frequently stop at our translation to patient, from, let's say, molecule or process to patient. And a lot of times, really, the steps to bringing this into practice, even in a confined environment, if you want, of a hospital, or from there into the practice overall of wider society, are the steps that are much crucial, but that are taken much less than the others. So most of our research really happens in the T0 to T2 phases. When it comes to implementation research, there are several aspects that are being taken into consideration that are important also for other types of research, for other phases really of the research cycle. But here they become crucial and if you want, more important and more emphasized than in other phases. And the things that I mean here is the first step is the evidence-based-ness of the intervention. Of course, we could have a discussion about what that means. And I think what we need to point out here is that it is not just the result from a randomized clinical trial, but evidence-basedness can also be based on practice experience, for example. So the approach here, especially in implementation research, can also be somewhat different. The importance of the setting, the fact that you are trying to implement something in a specific and peculiar setting with its own rules, with people who live in this and who have been living in it for a long time and who have certain expectations and maybe also certain fears about healthcare, and how do you take that into consideration? It should be ethically sound. You don't want to do, in any case, any research that's not ethically sound. But in this context, especially if you work, for example, with disadvantaged individuals that have less access to information about healthcare, who might not have the opportunity to make informed choices, it's even more important. It should be done by researchers and users, so you should have a combination of stakeholders, and the users might sit exactly at the same table as the researchers, bringing in their experience. And it is a systems perspective. So you're not looking at a molecule in a lab or a therapy within a hospital context, but actually you're looking at the broader healthcare system. So here again, I just put them together for you. These are the guiding principles that are being taken into consideration when we talk about implementation research. So how does that work for sex and gender sensitive healthcare? So this is a workshop we have done several years ago in the context of a EU project, and my colleague Petra Verdonk, which you will see afterwards again in our discussion after this, was also part of. And we asked really practitioners and researchers and public health experts, well, why does it matter? Why should we include focus on sex and gender in the practice we're doing? And as you can see, there were several layers that were being mentioned. And the first one, if you want, you can call it ideology in one way or another. It's about health equity. It is important to remove barriers to access. It's about social justice. So all these big themes that move us when we go into this field. Then it has a dimension of outcomes, so it could potentially improve the healthcare for everyone. It can lead to better quality of life. It can change our practices. It has a component of empowerment, especially of the users, which might be empowered to a completely different level than they usually are in traditional research. For example, think about a randomized controlled trial where, yes, you participate, but you are really a subject participating and you don't have much choice about the single things that are being done. It has an economical aspect, so potentially by taking into consideration the specifics of participants, you might actually end up saving money rather than giving one intervention to all and then finding out that it has severe consequences or side effects, and it has down the line costs. And of course, a policy aspect of changing things. So these are all the things that we hope to include, and how do we do that? So is it enough if you have your project, you design it, you water it with a lot of good intentions, and then it becomes a sex and gender sensitive project? Is it that simple to just have this background and the hope to include it? Well, of course not. And there are many layers of how you can actually move a project from being gender unequal to becoming a project that addresses or that achieves, ideally, gender equity. And what you see here is a graph that was initially designed by the WHO, but it has been used in several publications over and over again. And what it really shows is that there are so many different layers to how far you can really incorporate an attention to sex and gender into your projects. So the first ones, these are the ones that we hope you will never be doing again after attending the school, is gender unequal projects, where you don't even consider the fact that sex and gender might play a role. And the second one we also kind of hope you wouldn't be doing again, which are gender blind. So not only do we not want you to ignore this and not perpetuate this, we would like you to move directly to the next steps. But also these next steps, they're not all at the same level. So we have gender-sensitive projects which acknowledge the existence of differences, but you could imagine this a bit like a shrug, like, yeah, there are differences, unfortunately, that's it. Then you can have gender-specific approaches which address the differences that you're finding. Oh yeah, we find that women are disadvantaged, or we find that men are disadvantaged. Let's do an add-on project for this group. And ideally, what you would hope to find, or what you would hope to develop when you develop an intervention that is gender sensitive, you would hope to get to the level of it being gender transformative. So to have enough understanding of the mechanisms that are behind the processes that you're addressing to make sure that through your intervention, you're actually addressing the root cause of what is leading to these inequalities. And that would eventually increase the equity, the gender equity that you have in your system. So as you see, there's many different levels of how you can incorporate that. And let's be frank, very few projects actually achieve any level of gender transformativeness. We're mostly, if we're lucky enough, we have gender sensitive and gender specific projects. But of course, there are new steps, and that's why we're training you, said that you will be doing a lot of gender transformative projects in the future. This is just a reference, if you're interested, again, from the project I mentioned before. We compiled a list of how and at what levels you could possibly consider gender in implementation, and how could you do that with which stakeholders. And we modeled this on a recommendation list that was implemented generally, generally for implementation, with 72 steps. And we basically try to see, well, how do these 72 steps, how can these be adapted to sex and gender sensitive implementation? All right, but what does that mean in practice? And how can you implement, for example, a gender sensitive treatment for coronary artery disease? So this is maybe the one topic that has been mostly addressed in the field of sex and gender sensitive healthcare is cardiovascular disease. And this is really one of the topics where we assume that most of you have some knowledge, and maybe people in the general population sometimes have more knowledge than practitioners. But anyway, just to sum it up, we know that women, and especially younger women, can have less symptoms when they have a heart attack. It actually says heart attack here. I just see that. So a heart attack. They can have less symptoms, or they can have more diffuse symptoms. And the older they were in this group of more than 1 million reports of myocardial infarction investigated in the United States, the older they were, the more typical their symptoms were. So the more frequently they had pain on the chest irradiated to the left arm. The younger they were, the more diffuse symptoms they had. Sometimes they had no symptoms at all, and sometimes they had either shortness of breath, or, for example, nausea or lightheadedness, and so forth. So this is, I wouldn't say common knowledge, but relatively common knowledge by now in the general population that there are differences in symptoms. So this is not the typical depiction of the heart attack anymore. I still use this to study, and maybe some of you still use this. This is a picture from the Netter. Netter was an extremely gifted painter and a physician, and he left us with hundreds of vignettes of what diseases would look like in a vignette, which helped us all study. But I would say this one of the heart attack maybe a little bit surpassed by now. However, try to Google heart attack. And I did that several months ago. And what you will find is this. So you will find exactly 4 women, and one of them you will find twice. And so, yes, we know, but then if we look at our collective unconscious, we see that still we're not completely there, although we're moving forward. So what does moving forward mean? First of all, that you have also depictions of other people and not just elderly white men who have had a large meal having a heart attack. And most important, that you might actually move on to, for example, what the American Heart Association is doing here, to not gendering these symptoms at all, to simply mentioning that there is an array of symptoms that can associate with a heart attack without attributing them to women or men, and simply listing all of them as potential symptoms. How do you get there? So the process to get to these changes is not one that tomorrow you decide to change things and everybody knows about it. It's a really long process that takes many stakeholders into account, as I said before. So of course, the first step is you need to identify a problem. So you need to see the problem that women, especially younger women, were having heart attacks that we didn't even think they could be having. So first of all, the problem needs to be identified. Then the next steps you will need to be taking is you need a lot of science. You need science that will help you identify the causes at the provider level. So what are healthcare providers doing maybe suboptimally? Then what is happening at the population level? So for example, do people ignore the risk that they could have a heart attack? Then you have to look at the clinical causes. So what happens? What are the symptoms? Are there differences in symptoms? When do they happen? Can we do anything about this? And then, of course, you would like to know, is there anything specific about the transmission of pain that differs, for example, in female or male participants in a study? So you need basic science. However, that's not enough, because science does not automatically and osmotically translate into changes, as I've shown you before. So most of the things that we find out will stop at the T2. So you need to inform the general public about these findings as well. You need to bring all of that knowledge somewhere to the general public. You will need organizations to support you in that. And usually the step is that you first have parallel organizations and then you have official organizations. And what I mean is, for example, specific working groups within professional societies will form first to maybe look at sex and gender differences in a field, let's say nephrology or oncology, and then the official mother organization or father organization will pick up the information that the working group has developed and integrate it into their general approaches. You will need to teach a next generation of scientists and practitioners and clinicians and researchers what you are finding. No, that should stay. You will need public advocates. So you need people with a lot of other people listening to them, ideally famous people who will support you in bringing out the message, because as scientists, generally, we're not famous enough to reach everybody. So that is, of course, helpful. And sometimes, especially in the United States, these turn out also to be funders. That happens much rarely in Europe. Eventually, you hope to change legislation in a way that makes it mandatory to actually implement the things you have found or the new processes you want to implement. You need guidelines. You need postgraduate training. And finally, you would hope to achieve some sort of standardization. So the way it is happening right now is that kind of these processes happen each in its own way. But if you think about it, really, the things are all interconnected, because unless you have a problem identification, you don't know what to tell the general public. And unless the problem is identified, you don't really know what science has to do in order to give us more information. The science that you will produce, you need to better define what the problem is and what we could do about it. You will need science to inform teaching. And on the other hand, the people you have taught might become the scientists that give us more information. The general awareness in the public might pressure legislative change, and legislature might actually force organizations to look into this. And then if organizations are forced into this, they might produce guidelines, which are informed by science. So you can see that I could put in 100 other arrows. But the whole point here is all of these things are interconnected. And as long as we don't treat them in an interconnected fashion, the problem is that they slow each other down rather than accelerate each other. And this is one of the essential aspects to keep in mind when you try to implement anything. Now, a few examples of what I was talking about a few minutes ago. You can have wonderful gender-sensitive guidelines. So these have been developed in the United States by the American Heart Association since the beginning of the 2000s. This is actually the third update. And what you see here, for example, they're specifically designed for women. So they take several life course events or risk factors associated with life course events, so with menopause, with pregnancy, with a higher risk of having autoimmune disease, changes in the immune system through life course event, and so forth. They take them into account and design specific guidelines that are adapted for women. They come out of a somewhat parallel organization and then eventually were picked up by the official organization, which didn't happen overnight. It happened because there was societal pressure to actually look into this. When it comes to gender-specific prevention, as I said, we rarely have transformative approaches, but we have a few good examples of gender-specific prevention. One of them is Wise Woman. Wise Woman is a program that has been developed in the United States. You can find it on the CDC website. And the crucial thing of Wise Woman, which is a program for underinsured or uninsured women between 40 and 64 years of age, is that it is designed in a way that you can adapt it to the context. So what I was saying before about the relevance of the lived experience and the lived environments of people is taking into account here. So you can download the materials and then you can see how can my organization, which has been working in the field before, adapt these into the context we're working in. The same thing goes for a gender-specific prevention program for men. This is Football Fans in Training, which has been developed in the United Kingdom and is now being rolled out as Eurofit or tested as Eurofit all over Europe. It's a program for overweight men, which are not physically active. It's a 3-month program, which has built on extensive research on masculinities and overweight. And basically, why is it called Football Fans in Training? Because the program takes place in the football clubs that the men who participate prefer. So basically, they get to train in the football club and they get to meet the coaches. And a lot of the training and information they're being given is done on those facilities. So both of these programs are rooted really in the community and have been developed with the stakeholders in mind. Does that happen in clinical as well? Well, not that often, but it is quite possible. And this is actually an example of how not explicitly mentioning the sex disparities, but addressing them in a transformative way improved the outcomes for everybody involved. So this is from the Cleveland Clinic in Ohio. And what they saw was that there was a disparity between the treatment that women were obtaining when they came in with a myocardial infarction and the men were obtaining. And that was in all indicators and also in terms of mortality. So they came up with a 4-step protocol, which doesn't mention sex at all, but it has 4 standardized steps. So the steps are at different layers. So the first one is, initially, it was necessary to have a consultation between the ER physician, the interventional cardiologist, and the cath lab, and the consultant cardiologist. So that was abolished. There was no cardiologist consulted anymore, but the ER could directly communicate with the interventional cardiologist. So that happened directly. A protocol was in place which clearly laid out which information had to be collected at the same time, possibly from the ER nurse, from the interventional cath lab nurse, and which kind of checklists had to be used. It was put in place, a policy was put in place that a patient who qualified would have to be sent to the first available CAT slot. So you would not have to wait for any other consultation. If there was a slot available, the patient would be sent through. And there was a decision being made on the use of radial access rather than femoral access. So to do a catheterization, you can use either veins in the arm or in the leg. And by implementing these 4 steps, and as I said, they don't mention sex at all, but it was designed per se to abolish the sex disparities, the program was extremely successful. And you see on the left-hand side, the blue bars is how it used to be before the implementation of the protocol, and the red bars is how it used to be after the implementation of the protocol. And you can see that something like this is possible, but of course, it is a hospital-wide rollout that needs to be done. Okay, a few factors that can change the ability or the willingness or the success of an implementation process. And I specifically talk here about the adoption of an innovation, because at the core, when we try to implement sex and gender sensitive healthcare, what we're doing is really an innovation in what healthcare is like today. So we're changing the way we're doing it. And there are these 5 steps or 5 layers that do influence the likelihood of the adoption of an innovation. The first one is it a relative advantage? So is doing things differently gonna improve what we're doing right now? And the last example I just showed you of how changing the protocol actually improved outcomes for everybody is, of course, a clear signal. So there needs to be a potential relative advantage. That could also be financial, for example, or that can be PR, or, there's different levels and layers that can be taken into consideration. The second level is compatibility. So the system where you're trying to implement an intervention or a program or a product, in how far is what you're trying to do compatible? And this is what I said before with Wise Women, for example. You have a general program that can be adapted to the environment. And so to make sure that the prevention you're trying to implement actually resonates with the community you're working with. The complexity of the program plays a role. How difficult is it really to do this? How many layers are to this? How many steps have to be taken? The program I showed you in the hospital, it's really 4 steps. Of course, it's complex to design these, but it is really 4 relatively simple steps. And that, of course, makes implementation more simple. Divisibility is another question. If you have a complex intervention that will run over years, can you possibly divide it in chunks? And do the first steps first, see how it works, see how people are picking it up, and then possibly do other steps. So is it possible to split that? Sometimes it's also a question of financing. Maybe a financing institution will give you money for step 1, but not step 2 or 3. But if step 1 is successful, you get the opportunity to go on. And last is communicability. And that's, well, within the organization and within the peers, but also towards outside. So how can you justify an intervention or a change that you're doing? How do you communicate that to the wider community overall? And all of these together will change how fast and how much your innovation or your sex and gender sensitive process is implemented. There is another layer to be taken into consideration. If you work with an organization, there are factors within organizations that play a role, and that has to do with what are the goals of the organization overall. So does it actually match? It's a bit in the direction of compatibility. How are the roles and the authority structure within your organization, which has an impact on how decisions are being taken? If you work in a very authoritarian organization, you can have all the bottom-up ideas that you want. It will be very, very difficult to do that. It's not impossible, but it's very tricky. If you have an organization with a very flat hierarchy, it might be relatively meaningless to have an absolutely top-down structure because it will collide with the DNA of the organization. There's rules and regulations in any organization that you have to take into account. And of course, most importantly, the informal patterns. And if there's one step to take importantly into account is who is actually deciding what within an organization or who's responsible for what. And that's not always the person who is formally assigned to do that or the person who has the hierarchical position to do something. A lot of times, these are other people who have been in the organization for 20 years, who know everybody, who know how everything works. And knowing these informal players might actually speed up your organization and save you months, if not years. Again, as I said in lecture number 2, when I was talking about the prevention of harassment, you need a window of opportunity for an implementation of an innovation. It can be anything, but you need a moment where people feel that things need to change one way or another. You can generate that possibly by providing enough knowledge, but you need to create a moment where there is an opportunity. And now to the concluding remarks. So when it comes to implementation overall, what can I recommend? It is important that you know your organization or the setting you're working in. So what are the patterns? Which kind of people are working here? What are their ideals? What moves them? What makes it difficult for them to possibly adopt this innovation? How can you adapt whatever you're trying to innovate to accommodate these settings? Possibly identify early on chaperones, so people who are heard in the community or organization, and possibly communication nodes. So there's always people within communities or within organizations who know everybody, who know everything that's going on and who know everybody. And try to find these people because they can help you enormously in spreading the word, in recruiting people, in bringing the information out there. You want to know how the culture is. And as I said before, you want to know how the informal hierarchies are and how the informal culture is, because you should include that into your design. So if you know who informally makes a decision, and that might not be the CEO, or that might not be the community leader, but actually somebody around them, and you include that into your design, you will be much more successful. And be mindful of the fact that any structure has informal culture and informal hierarchies. The formal ones are only on paper, and every organization has informal hierarchies and informal culture. Sometimes they're more expressed, sometimes they're less, but they're always there. And then, of course, when you do a study, compare the enrolled population with the real population you're trying to reach. How far do they overlap? Are you actually getting enough information? Do you include everything you need? 2 steps after having done the research, when you report your outcomes, you're not writing a scientific paper. So you might also be writing a scientific paper, but if you are aiming towards implementation, you should try to write these outcomes for decision making. So write in the next steps that need to be taken on in the decision making process. And what's important here is to know the policy making cycle of the organization, of the environment you're working in. Even if you work with a certain area in a city, you want to know if there are moments where communal decisions are being made, where the city council is meeting, and so forth. So make sure that you prepare your results or your proposals in a way that's actionable, and make sure that you present it at the right timing. And the right timing is not the grant. The right timing is actually what's happening in the real world. And last, think about how this could be institutionalized. So this is something that you should actually take into account while doing an implementation process, and think about how in the long run this can be institutionalized. How can it be stabilized? What can happen after the financing for the project is over and after this specific project is over? Now to my last slide, where are we now, and what does that mean for sex and gender sensitive healthcare overall? So this is a graph that some of you might know. It's also used in marketing a lot of times. Products are usually, or innovations in general, are usually taken up in different moments by different people. So you usually have a small group of early innovators, which are sometimes such crazy innovators in quotation marks that they're really detached from their peer group. So them picking it up doesn't automatically mean it translates. But then you have early adopters who are usually well-known within their community, influential people that can actually make sure that something is picked up. And then you have different layers of majority and laggards, who are the people who wish they didn't have to do this, but eventually might have to do it anyway. And as you see, over time, change happens. So we, in terms of sex and gender sensitive healthcare, are here, I would say, somewhere between the early adoption and the early majority. And to move what we're doing to the level of institutionalization, we really need to get this concept of broad stakeholder engagement and bringing together different moments of stakeholder engagement more at the core of what we're doing, so that we can move to the next level. And with that, I thank you very much for your attention, and looking forward to your questions.
Thank you, Sabine, for your talk. And now we have a discussion with 2 other scientists. Petra Verdonk, you're from the University Medical Center in Amsterdam, and also a specialist in gender and sex and intersectionality. And Marijn van Wingerden, assistant professor at the Cognitive Sciences and Artificial Intelligence of Tilburg University. Marijn, Sabine told us about the basics of implementation, and she mentioned ethically sound. Does that refer to your way of looking at sex and gender also, that it has to be ethically sound in AI, for instance?
That's a very interesting question. So it reminds me of a couple of things. One is the recent controversy about the Google ethical AI team, where there were some high-profile layoffs, actually, of 2 female researchers, Timnit Gebru and Margaret Mitchell, who were voicing concerns about ethics in AI. And rather than this being picked up, they were actually dismissed, quite publicly so. This has led to large outrage, and I think, therefore, also it can be seen as a force for good in the end, but of course at a large personal cost. So ethics are very important for implementation. And I was also interested by your example about the Cleveland Clinic, where if I can paraphrase, they implemented some sort of stealth adaptation by not saying actually what was going on, but designed the intervention in such a way that
without
actually,
mentioning sex and gender.
exactly, so that in one way it might actually circumvent what I would say something like harmful heuristics that might actually hinder decision making, right? Just by not phrasing it in terms of masculine or male or female interventions in a way. And this brings me back to AI, because there is the possibility to incorporate protected attributes in models that are implemented in AI systems that are used for a whole range of things, like decision making or decision aids, both in categories where sex and gender are maybe important, such as healthcare, and in other sections of society where it shouldn't matter at all, like who qualifies for a loan, for example. So some thought has gone into that, how to avoid bias, basically, in machine learning and in artificial intelligence.
But
and
but if you look at AI, do you need the concept of gender and sex to get it ethically sound?
Yes, because I think if you're not aware of it, you cannot protect against disparate impact. So we know that the data that we're working with is inherently biased. And if we would, I think this would be the first step, actually, that you outline, sort of willfully insensitive research, right? If you don't acknowledge the fact that gender, sex, and for example, skin color can have a huge influence in these type of models, artificial intelligence, then you're putting on the I don't know the word now, but sort of you're narrowing your vision. So and the answers that you're going to get are most definitely wrong, basically. So ignoring that is not an option.
Yeah. And Sabine, was it the intent to get rid of sex and gender in Cleveland, just to get more support to change it? Do you know that?
I don't think it was about the support. It's a bit, I think, like the process of the one figure I showed with the symptoms, where in a way you're taking it out, but you're making it applicable for everyone. So in a way, these are human symptoms, and we shouldn't just attribute them to one group or another. And so we start a whole discussion about, but that's only 5% of people who have that. Mm-hmm. These are just human symptoms. And here, I think the whole point was, maybe, I don't know if that went into the decision-making process, but it's quite possible to say, well, we try to develop an algorithm that's best for all of our patients, regardless of who they are. We take into account all these differences to design it, but it becomes something for the best possible care.
Yeah, sometimes you do it on purpose to get the support of other people.
It's possible. I don't know. So I don't know if they specifically did that. I don't think so, because I think it is quite well known that there is a certain bias in for example, door-to-balloon times, and that women a lot of times obtain somewhat suboptimal care when it comes to the interventional care. So I think for professionals in the field, this is not something you can hide in one way or another, because we're acutely aware that it exists. But really just designing it as something that improves care for everyone, I think was also, if you want, a political step, but not so much to hide the sex and gender sensitivity, but to say, okay, this approach actually improves it for everybody involved, which is a bit of what we're trying to say anyway, because if you take this into consideration, as you were just saying, it improves the output for everybody. So in a way, it's a way to get there.
Yeah. Petra, as associate professor, I think you always mention a better quality of life, isn't it, in your research, if you take into account gender and sex?
Better quality of care, healthcare generally. Well, yes, better quality of life, that could be, but that's for people to decide whether they think this improves their quality of life. But I think it's a step towards better research quality and better healthcare quality. Absolutely.
Yeah. But is it necessary for implementation that you mention gender and sex?
Well, I agree with
Marijn,
because you need to be intentional. So it's very beautiful that this particular topic works out in the way, the Cleveland example, that it works out in the way that it does, but it won't do the same thing always. Mm-hmm. So you have to look at what the health outcomes are that you want to improve. And for this one, for instance, in myocardial infarction, where women have more atypical symptoms, as this is often called, but there are also men with atypical symptoms. There it would definitely improve healthcare for everyone, because it would also improve men's health outcomes.
Yeah.
If you incorporate the atypical symptoms in your protocols. Yeah. But it won't be the same for every health problem.
Yeah.
So
but is it therefore necessary that patient participation in this type of research of sex and gender is very important?
I honestly think that it's always important, whether you do AI, whether you do,
but also in the conceptualization.
Absolutely, you just have to understand whose problems you are addressing, and therefore you have to involve people in the research that you're
also
doing.
In the design.
Already at asking the research question. So at the very beginning, you have to involve patients and people whose lives are concerned, or whose lives you address in your research. Yes.
And in cognitive science, do patients or specific groups already are involved in designing the study?
Yes. For example, in the patient groups, some patient groups that are representing people with autism spectrum disorders, for example, have been very vocal in trying to steer research design into in that particular area. I'm not so much aware of patient groups in particular asking for gender-sensitive implementations, but that might just be my field that is underrepresented there. I'm not sure.
No, the problem is when you involve patient groups, that very often you see the same gendered patterns that you see in every organization, which is that the men are more often more vocal than the women. So there's that to address. But involving people in asking the questions that they find most important is very relevant, because researchers and doctors tend to study what they find interesting. And that's what I do too. We study the things that we find interesting and important.
But you always have to into consideration the clients and patient questions
exactly.
Instead of your own interests.
Exactly. But so therefore you have to understand their lives.
Yeah.
And in order to understand their lives, you have to be in touch with them and ask and involve them.
Yeah. Sabine, when I hear your story, your lecture, I wrote down the word, you need a lot of activism as a scientist.
Yes. Both the deans of the two universities I work at told me face value, you're an activist, but in a good way, whatever I take from that.
Yeah.
And I think it's an absolute part of what you need to do. I think at least if, I think there's different types of research, but if you want to change the practices the way I described here and the way I try to do, you cannot get around being an activist in one way or another. I mean, it's also a question of what does it mean to be an activist? I mean, do I go out and throw rocks at windows? No. But does it mean to actually build coalitions in where you change the world we're working in, the world we're living in? Absolutely. I think it's an essential part of this. And of course, you will also encounter resistance and people that tell me, well, this is not scientific. Well, yeah, so be it. But one day I'll retire and I hope to leave a legacy behind. So it has also to do with what you want to do overall. I think it is, but it's also a bit of a personal answer to that.
Petra, is that why Sabine also strengthened and had a very strong plea about stakeholder engagement for you as a scientist, stakeholder engagement? Does it resonate you?
Yeah, well, you need, in order to engage other people, which is what you're doing with activism in a way, you're trying to do, you try to involve the people who can make a change. When we talk about the implementation, we talk about social change. And as we are standing here, I assume that we want better health and better health care, which is, I would say, an ideological position, which means that we are activists. And the way we do it, and when it comes to sex and gender, there is this particular extra that you have to have compared with other fields, because you are not yet established. Your topic is not yet established.
So what was your bumpy road in your hospital, for instance?
Well, there's always something around the corner that you have to address. You never know. Like, so sometimes I've done a lot of work in implementing sex and gender in medical education, and then you have established that, and it's all in there, and you have your learning goals, and everybody's happy, and then there's a curriculum transform, and there it goes again, right out the window.
And then you have to make the plea again.
And then you have to start all over. And this is our work in a way. That's what I tell my juniors all the time. Like the articles that we write, we write them to stay in the business. But this is actually the work that we have to do to make that change.
Yeah. So you should be a kind of advocate also as a scientist.
I think also an ally. So we have, of course, our activists that are very vocal on the national and international scene. But I think too often these are very vocal women. And so where are the men? Right? We should support this structural change. And I think it's too easy to just pay lip service and say and nod and say, yes, well done.
Or do it yourself as a man.
I have to do it, yeah. And so it is about continuous implementation and not just a one-off for a certain change, but to make sure that it sort of sticks. And I think that starting at sort of the lowest or the earliest stages of education is probably the best way to make it ingrained. And I guess the hope is that it will stick, and it might take some time, but change will accumulate.
If it comes to sex and gender, is there already some things institutionalized in Tilburg?
The fact that I have to think about it probably means no.
And in your institute, is there already some institutionalization?
Like in the sense that I'm certain that it will stay? No. No, not in the sense that I'm certain that it will stay when I'm gone or when it's not addressed. It's not that normalized, not in the culture, no.
And at Radboud?
I don't think there is any European country where it is institutionalized in the national curriculum plans in a way that it will stay after the chaperones are gone. Even if in in specific universities, yes, we have it implemented to a certain degree, but it is still, there is, to my knowledge, even in the countries where there's laws that actually demand it now, for Italy, for example, has a law, but it's not nationally institutionalized. So there is, to my knowledge, no country in Europe that has implemented it to a degree that it will stay regardless of having somebody holding the flag or not.
Yeah, even if there's a professor or whatever.
Yeah, it should, in theory, it should be part of a curriculum where you say, even if there's no institute or professor or just person who basically does the work, it will still be an essential part of the curriculum because it has to. And we're not at that degree yet, anywhere.
Well, maybe we can take this perspective and say that sex and gender sensitive healthcare is better healthcare, so that even if it would be absent, someone would reinvent it, by the way, in a way, because it's going to lead to better outcomes.
I think it's going to come up again.
Yeah.
I mean, in that sense, it will stay forever. This is not a topic that will go. It will come up again and again.
So there are some tides all the time. Yeah.
It's not linear.
In all implementation processes.
Okay. Well, thank you for this moment. And we go to the last topic of this workshop.